grand rounds. Priya, do you have your slide? And Dominique, do you have Dr. Deshpande's slides?
Oh, I can, should I share my screen? Hi, good
Yeah.
morning, everyone.
Hi. Okay. I will introduce you, Priya.
Oh, sure.
While you're sharing the slides.
Let me see if I can do this correctly.
It's up.
Can you see my slides?
Yes, we can.
Okay.
Okay. Perfect. So it is a great pleasure this morning to introduce Dr. Priya Deshpande. Dr. Deshpande received her bachelor's degree, double majoring in neuroscience and actually Russian from University of Rochester. So if you have any Russian-speaking patients with renal problems, you can certainly send them over to her. She then completed her medical degree from SUNY Downstate, internal medicine residency at Albert Einstein Montefiore, where I can personally attest that her calm, cool, and collected reason and clinical acumen got many an intern through a tough call. Dr. Deshpande then graduated from nephrology fellowship at Mount Sinai, and currently she serves as an assistant professor of medicine in the Division of Nephrology at Mount Sinai. Dr. Deshpande is the medical director for the Central Park Dialysis Center, and she's building an oncology nephrology program in collaboration with our multiple myeloma teams and urology teams. Please welcome Dr. Deshpande.
Thank you very much, Sophia, for the very kind introduction. Again, my name is Priya Deshpande. My talk today is on checkpoint inhibitor-induced renal toxicities, kind of a segue onto the fellows talk. It's been checkpoint-induced renal toxicities have gained a lot of speed in the nephrology community, and it's definitely an interest area for research for me. So I'm going to start. I have no disclosures. The objectives of this talk is to recognize and review broad causes and stages of acute kidney injury. We're going to also review checkpoint inhibitor mechanisms. We're going to review the types of renal injury associated with checkpoint inhibitors, and we're going to look at electrolyte disorders associated with checkpoint inhibitors. So we'll start off with a case. This is a 69-year-old man with non-small cell lung carcinoma, hypertension, GERD on a proton pump inhibitor. He was started on pembrolizumab and is now hospitalized with weakness and failure to thrive. Of note, his baseline creatinine was 1.5 and is now 3. His urine output is also slightly lower at 35 cc's an hour. This is, I didn't know how to do a poll question, but does anybody know what stage of AKI acute kidney injury he may have? Anybody want to call it out? So let's go over a quick review of acute kidney injury based on the KDIGO classifications. Acute kidney injury is divided into 3 stages. Stage 1 is less than a doubling of the serum creatinine. Stage 2 is between a doubling and less than a tripling of the baseline creatinine. And stage 3 is a tripling of the baseline creatinine or oliguria and urea or requires renal replacement therapy. So this patient has stage 2 AKI. Why is AKI bad? This graph looks at the absolute risks of clinical events in patients a year after they've been hospitalized with AKI. The red is mortality events. So all-cause mortality is increased, especially cardiovascular and cancer-specific mortality. Blue is cardiovascular events, and there's an increased risk of heart failure and atherosclerotic events after an episode of AKI. Hospitalization after an episode of AKI is also increased, and especially hospitalization with another episode of AKI is increased. And there's also an increased risk of developing chronic kidney disease and end-stage renal disease. So in terms of causes of AKI, this is going to be really broad. We divide AKI into three separate causes. The first one is pre-renal, which either is volume depletion or decreased effective vascular volume. The second cause of AKI is intrinsic, which is what we're going to be focusing most of our time on today, and that's parenchymal damage or glomerular damage. So this includes tubular injury, such as acute tubular necrosis, as well as acute interstitial nephritis, and glomerular injury, which includes glomerulonephritis as well as TMA, thrombotic microangiopathy. Obstructive causes for acute kidney injury, which we're not going to discuss today, are either obstruction in the upper GU tract or the lower GU tract, but those are the three main causes of AKI. So how does checkpoint-induced AKI differ from other causes of acute kidney injury? Unfortunately, there are no clinical features to distinguish the two. There's a multi-center study done through the Dana-Farber Institute with Cortazar et al. They published in JASN. They identified 3 independent risk factors for developing acute kidney injury in the setting of checkpoint inhibitors. And the first one was concomitant use of a proton pump inhibitor. The second one was combined checkpoint therapy, so including anti-CTLA-4 or anti-PD-1, PD-L1. So, the third one was baseline chronic kidney disease. So going back to our case, this again is a 69-year-old man with AKI, stage 2 AKI in the setting of pembrolizumab. And I wanted to take a poll on what people may think is the cause of his AKI. So the 4 choices are acute interstitial nephritis, acute tubular necrosis, hypertensive nephrosclerosis, and thrombotic microangiopathy. I'm sorry. I think my poll isn't working. Does anybody want to venture a guess?
People could poll through the chat also.
Oh, okay. Sorry. I don't know how to look at that. I apologize.
Oh, I see.
Do we have any guesses on the chat that you can identify?
You guys have to unmute yourselves to answer.
TMA.
TMA. We have 1 TMA. Anybody else? So everybody hold on to their answers. And
AIN.
AIN, very good. Okay, so we have a couple of different opinions as to what the causes of AKI is. Just hold on to your answers. We're going to talk about it in a second. Before going into the case in more depth, I wanted to discuss the concept of immunosurveillance. This is a nephrologist understanding, so obviously if there's something that's a little bit off, please let me know. But my understanding of immunosurveillance is for the immune system to recognize and eliminate potential cancer cells. This is divided into 3 phases. The first phase is elimination, when the immune system detects and destroys the tumor cells or cells with malignant potential. The second phase is equilibrium, when the immune system keeps in check the tumor cells that have survived elimination. And the third phase is escape, when the tumor cells themselves can acquire, they can either lose tumor antigens or acquire proteins to inhibit T cell activation. So this brings us to T cell activation and checkpoint pathways. So kind of basically for a T cell to be activated, it requires 3 signals. The first, and this is, we're going to quickly talk about the 2 different checkpoint pathways. So for activation of the T cell in the lymph node, the antigen presenting cell has to present the antigen on the major histocompatibility complex to the T cell receptor. The T cell then has to be, there has to be a co-stimulation signal between the antigen presenting cell and the T cell. And then the cytokine environment allows for the T cell to get differentiated. In order to inhibit the T cell, there's the CD8086 on the antigen presenting cell can interact with the CTLA-4 receptor on the T cell, and that causes inhibition of the T cell. An activated T cell, when it goes into the periphery, the peripheral tissues actually can regulate T cell activity as well. So the peripheral tissues have this PD-1 ligand, and when the PD-1 ligand interacts with this PD-1 receptor on an activated T cell, that can cause the T cell to become quiescent again. In the tumor microenvironment, some of the tumor cells actually acquire this PD-1 ligand, and the tumor cells themselves can suppress the T cell activation. So this kind of goes back to the escape phenomenon that we talked about in the last slide. So it would make sense to be able to block the PD-1 receptor, the PD-1 ligand, and in order to help promote T cell activity. And this is what the checkpoint inhibitors are designed to do. So here's a list of the FDA-approved checkpoint inhibitors. The ipilimumab works on the CTLA-4 pathway. Nivolumab, pembrolizumab work on the PD-1 pathway, and atezolizumab, avelumab, durvalumab work on the PD-L1. And as your fellow was talking about before, the checkpoint inhibitors have had very successful response rate in a variety of tumors, including melanoma, non-small cell lung carcinoma, renal cell carcinoma, and these anti-tumor effects of the drugs last long after discontinuing the drug, which can then predispose to adverse events. So, ultimately, the checkpoint inhibitors allow the host immune cells to identify and eliminate malignant cells, but then unrestrained T cell activation has its complications. So checkpoint-induced immune-related adverse events occurs in about 50% of patients, primarily in the endocrine, skin, and GI tracts. The renal adverse events are rather small, 1 to 2% with a single agent and about 5% with combined agents. The latency period between initiation of checkpoint inhibitors and acute kidney injury is longer than other immune-related adverse events. Dermatitis, for example, occurs within 4 weeks. Colitis can occur within 6 weeks. Acute kidney injury can happen between 1 to 8 months after initiation and up to 2 months after the last dose. And acute kidney injury in about 30 to 60% of patients can occur concomitantly with other IRAs or after the other IRAs. The most commonly reported extrarenal adverse events prior to acute kidney injury are rash, thyroiditis, and colitis. So as you can see here in this picture, the side effects or the adverse events from checkpoint inhibitors can pretty much target any organ system, including ophthalmologic, cardiovascular, renal. So going back to our patient, again, this is an elderly guy who got a pembrolizumab, and he had stage 2 acute kidney injury. So this patient did not have any peripheral eosinophilia. He had about 2 grams of proteinuria, which was new. And the urinalysis showed numerous white blood cells, but the urine culture was negative. So he had sterile pyuria. And this is a picture of his urine microscopy. So as you can tell, there's a cast here in the center of the screen. It's a cellular cast. We're trying to figure out what kind of cells there are. This cell here, sorry, I'm having a hard time with my screen for a second. Can everybody see my pointer?
Yes.
Okay, this cell here, this is a red blood cell. It looks like a perfect little dewdrop. And this cell up here is a white cell. So ultimately this cast looks like it's comprised mainly of these white cells. So this is a white cell cast. Then this patient was actually biopsied. So we'll quickly go through the biopsy. This is normal tissue. There's no glomeruli in this picture. This is like interstitial tissue. This is the renal tubules, and this is a very healthy appearance. This side is a very healthy appearance of the renal tubules. They're back to back. There's no debris in the lumen of the tubules. On this other side, however, this is the patient's biopsy. As you can see, the lower power, the normal architecture of the tubules have been kind of obliterated here. On a higher magnification, there are mononuclear T cells that are infiltrating into the tissue, and as a result, and this is ultimately the pathognomonic for acute interstitial nephritis. So what's the mechanism for acute interstitial nephritis? There are 2 hypotheses, one of which is self-reactive T cells are present even in healthy individuals, and when we block the CTLA-4 and PD-1, this may actually trigger autoimmunity. And the second hypothesis is that there is loss of tolerance of effector T cells that have been previously primed by another drug, such as a proton pump inhibitor. This slide summarizes case series with biopsy-proven acute, like pretty much biopsy series, looking at patients with acute kidney injury. So all of these patients have been biopsied. So in total, there are about 47 patients, and 27 of these patients actually had acute interstitial nephritis. And the majority of these patients did receive steroids, and many of them made a complete or partial recovery. The interesting thing on this slide is that it's not always acute interstitial nephritis. If you look at this, this paper here by Izzadine, they had 12 patients, only 4 of which had interstitial nephritis. 5 of these patients actually had acute tubular necrosis. And then 2 of these patients had glomerular disease. They had minimal change disease. This paper here by Mamluk, they had 16 patients which they biopsied, of which only 9 patients had glomerulonephritis. So that slide highlights the need for renal biopsies, especially in severe AKI. So for patients with biopsy-proven acute interstitial nephritis, we recommend, for stage 1, stage 2 acute kidney injury, we recommend oral steroids, about 1 milligram per kilogram. And for stage 3 AKI, we recommend pulse steroids followed by a course of oral steroids. The course can be as long as 3 to 6 months with a slow taper. And the acute interstitial nephritis can occur in patients that are rechallenged with the checkpoint inhibitor. So here's another case. Sorry, I apologize. This is a 57-year-old man with urothelial cancer of the bladder. He's status post TURBT, neobladder, and he had 11 cycles of nivolumab, and he was admitted for AKI. He had invasive high-grade papillary carcinoma with invasion. So he was started on nivolumab. This is back in 2017. His creatinine was about 1.6. After 11 cycles of nivolumab, his creatinine increased to 2.3, and the patient was admitted for a renal biopsy. So this patient actually had acute tubular necrosis. Even though the cases between the first case and the second case sound very similar, the biopsy was pretty different. So if you remember that slide about with the normal tissue, the tubules are nice back-to-back appearance, this is very different. In this slide, there's loss of the brush border, there's flattening of the epithelial cells, and there's some granular cast formations in the tubules. This is consistent with acute tubular necrosis. So, so ultimately, for this patient with acute tubular necrosis, he really has one of the best chances of renal recovery, almost complete renal recovery with just supportive care. This patient may not need treatment interruption with their checkpoint inhibitor. He wouldn't need steroids for treatment. And again, this highlights the importance of the biopsy to really figure out what's causing the acute kidney injury. So even though, and then the next, in addition to acute kidney injury from interstitial nephritis and acute tubular necrosis, glomerulonephritis has been increasingly seen with checkpoint inhibitors as well. And these patients may present with either nephritic or nephrotic signs. Just as a quick review, nephritic syndrome, pretty much these patients can be hypertensive. They have proteinuria, but it's usually less than 3 grams in 24 hours. These patients also may have an active urine sediment, which means that they have red cells in addition to the proteinuria on their urinalyses. And in patients with nephrotic syndrome, these patients may also be hypertensive. They may or may not have acute kidney injury. Some of these patients present with just high-grade proteinuria without any acute kidney injury. So they have nephrotic range proteinuria, and these patients may actually have anasarca. So glomerular lesions have been identified with ipilimumab, both so membranous nephropathy and minimal change disease have been identified with ipilimumab. There's also been a case report of thrombotic microangiopathy as well. And for both pembrolizumab and nivolumab, minimal change immune complex GN as well as crescentic posse-immune GN has been identified with pembrolizumab. Membranous nephropathy, immune complex glomerulonephritis, ANCA negative vasculitis, and FSGS have been identified with nivolumab. I'm working on a meta-analysis looking at glomerulonephritis and checkpoint inhibitors with a group from Canada. So I'll be interested to see what we discover there. So here's an algorithm looking pretty much for evaluating and treating checkpoint inhibitor-induced acute kidney injury. So if a patient has stage 1 AKI or low-grade proteinuria, these patients, if we pretty much just follow them, they can probably continue their checkpoint inhibitor therapy. However, if they progress to stage 2 or stage 3 AKI or develop high-grade proteinuria, definitely consult your friendly nephrologist, and it's probably better to stop or at least hold the checkpoint inhibitor therapy at this point. For patients who have potentially checkpoint inhibitor-induced AKI, especially if they have immune-related adverse events such as sterile pyuria or white blood cell casts, it may be worth treating them with steroids first and seeing if they respond to that. If the nephrotoxicity doesn't recover, then they may need a kidney biopsy. For patients who have acute kidney injury without any other signs of adverse events, or if they have high-grade proteinuria with red blood cells or dysmorphic red blood cells, these patients may benefit from a kidney biopsy to determine whether there is acute tubular necrosis or other immune-mediated renal lesion. So there's always a question of re-challenge. So patients with severe AKI, it's reasonable to hold the checkpoint inhibitor. There's a multi-center study through the Dana-Farber Institute. They re-challenged 31 patients at a median of like 1.8 months after their episode of AKI. Most of these patients were challenged with the same drug, and some of these patients were actually on steroids at the time of re-challenge. So about 23% of these patients developed AKI again, but within a slightly shorter time frame, about 1.5 months. But then 77% didn't develop AKI after a re-challenge with the same drug. So I thought this was pretty interesting how most patients, even after receiving the same drug, they didn't develop AKI. So now we're going to switch gears here slightly to checkpoint inhibitors in renal transplant patients. We have this is a 57-year-old woman who had a living-related renal transplant 15 years ago. She's on tacrolimus cellcept and has metastatic squamous cell carcinoma of the skin. Which of the following is likely to cause rejection? Does anybody want to take a guess? Is it the CTLA-4 inhibitor? Is it the PD-1 inhibitor? Is it a combination?
Combination.
We have a combination vote here. So this slide summarizes case reports in patients who've received, who've had a renal transplant, who received checkpoint inhibitor therapy. And actually it seems like the PD-1 inhibitors have an increased risk of causing rejection. And most of these patients had cellular rejection, which is T-cell mediated. So the hypothesis for the reason why the PD-1 inhibitors may increase the risk of rejection is that it seems like there's the PD-1, PD-L1 interaction may play a role in graft tolerance. There is this case report that was published in the NEJM by Barnett, and I think they had a transplant patient who received pre-treatment with sirolimus and steroids prior to receiving nivolumab, and they think that this may have prevented the adverse event effects on the transplant. Has this strategy been used by any of you guys? So the last part is checkpoint inhibitors in dialysis patients. Checkpoint inhibitors are not renally cleared, but the data about their use and outcomes in ESRD patients is scarce. So this is especially important because many ESRD patients have a higher risk of developing renal cell carcinoma. There's a single center study of 8 patients, and they found that checkpoint inhibitors can be safely administered to ESRD patients, and the rate of immune-related adverse events were similar. And there was a series of 26 patients, and they had similar findings. Oops. So now we're going to change gears to checkpoint inhibitor-associated electrolyte disorders. So here's a case that I saw in clinic. This is a 67-year-old man with history of bladder cancer, status post TURBT. This patient had muscle-invasive high-grade papillary urothelial cancer. He received gemcitabine, cisplatin, and nivolumab. His last dose of nivolumab was in May of 2019. And then in August, he was hospitalized for severe hyponatremia, sodium of 105, which was thought to be secondary to SADH, and he was DC'd with a sodium of 129. He saw mean renal clinic, and he was hypotensive to 89 over 50s. Sodium was down to about 124. He appeared maybe slightly hypovolemic on my exam. Of note, his urine sodium was 89. His urine osmolarity was 700, and serum osmolarity was 272. So this patient was admitted. His blood pressure responded to normal saline, but then, and I think his sodium responded initially as well, but then it went back down again. So what is the cause of this patient's hyponatremia? Is it SIDH? Is it adrenal insufficiency, hypophysitis, hypovolemia, and appropriate ADH response, or E, all of the above? Or I guess I should have written either any of the above. Any guesses? So I think this patient probably could have any of these causes for hyponatremia. So we can quickly go into how to work this up. So the differential for hyponatremia in cancer patients is pretty wide. Many of these patients can be hypovolemic. They can have SIDH from like nausea, opiates. They can have ectopic ADH production. Even chemo such as cyclophosphamide can cause this ADH. These patients can have pseudo-hyponatremia. So I like to use this algorithm to help work up hyponatremia. So this patient had a sodium of 124, and his osmolarity was 272. So this patient has hypotonic hyponatremia, and he was asymptomatic. So then we look at the urine osmolarity. So if the urine osmolarity was less than 100, that would probably mean that he's drinking more fluid than his tubules can actually handle. His renal tubules can actually handle. So that's more like a primary polydipsia. But in his case, his urine osmolarity was about 700. So we then look at the urine sodium. So in a patient like him, so if his urine sodium was low and he had signs of low effective vascular volume, then he can either have contracted extracellular fluid, or he can have expanded extracellular fluid. So ultimately, if he has low effective vascular volume and he's volume deplete, he may have hyponatremia from hypovolemia, and that's because of diarrhea, vomiting. It could be the use of like high dose diuretics. If he's volume expanded and has low effective vascular volume, then that's consistent with liver failure or cirrhosis. This patient's urine sodium again was 89, so he probably didn't fit this category. He was, so he had a urine sodium of over 30, and he was slightly hypovolemic on my exam. So this may be consistent with, and he had no vomiting, so you may have this contracted extracellular fluid space, and which may be from possibly adrenal insufficiency. So hyponatremia and checkpoint inhibitors it's been described in both anti-CTLA-4 as well as anti-PD-1. And there are about 16 reports of hyponatremia and PD-1 inhibitors, and it's been related to adrenalitis, hypophysitis, and isolated ACTH deficiency. So the test to perform on this patient is to obtain an early morning cortisol. We have to make sure that the pituitary function is intact, as well as look at his thyroid function tests as well. We may consider doing an MRI of the pituitary or CT of the adrenals, and the sodium has to be carefully corrected to avoid osmotic demyelination syndrome. So going back to this patient was found to have very low random cortisol. It was less than 1. So he was thought to have adrenal insufficiency secondary to nivolumab. His pituitary function was intact. He was started on hydrocortisone, and his serum sodium climbed up to about 134. So there are other electrolyte derangements that can happen as well. There's a meta-analysis by Catini et al., and they showed hypokalemia and hyponatremia were more common in checkpoint inhibitors versus other chemo. The hypokalemia may be from endocrine involvement, such as Cushing's or hyperthyroidism, but it can also be from CTLA-4 inhibitor-associated diarrhea. So in summary, I think it's important to recognize acute kidney injury in the onset of new proteinuria or hematuria. It may be worth checking monthly urinalyses with routine labs when a patient comes in for treatment. Checkpoint inhibitor renal toxicity is usually occurs secondary to acute interstitial nephritis or acute tubular necrosis. But biopsying these patients may prevent treatment interruption or avoid unnecessary steroid use. Rechallenging may be appropriate after an episode of acute kidney injury, but AIN may occur in patients that are rechallenged and may occur faster than it occurred previously. And the most common electrolyte disorders are hyponatremia and hypokalemia. Thank you. Can I help answer any questions?
Thank you, Priya. I do have one question. So for patients who do have a checkpoint inhibitor injury with ATN, if they're rechallenged, is the ATN less likely to occur than if it was another form of renal injury? And the other question is, for patients who are deriving a huge benefit from for their cancer on this therapy, and if something like AIN and glomerulonephritis occurs, could there be a role for rechallenging with some sort of pre-medication?
So, so for your first question with ATN, ATN isn't really immune mediated at this point. So I think pretty much patients who have had ATN as a result of checkpoint inhibitors, they probably don't need any interruption of their therapy. Once their renal function is recovering with supportive measures, I think they can probably continue receiving their checkpoint inhibitor. The second question with glomerulonephritis and rechallenge, that's a little bit tricky. I think when it comes to glomerulonephritis, because especially in patients with like ANCA-negative vasculitis or crescentic disease, the injury to their kidneys may be very pronounced. And I mean, some of these patients, at least on the case reports, they have been treated with cyclophosphamide or Rituxan to help with reducing the rates, the inflammation from the glomerulonephritis. I think patients, I saw in 2 case reports where patients who had a GN were challenged again, and they did develop the GN again. So I think at that point it's kind of like a risk versus benefits with the patient. Patients who've developed a glomerulonephritis in the past have had recurrence. And I think there was actually a case where they rebiopsied the patients and they had the same cryptic process that was happening initially. So I think especially if they're responding very well to their therapy, I think it may be a risk versus benefits discussion with the patient. Does that answer your question?
Thank you.
Are there any other questions?
Does anyone else have any other questions? Okay. Thank you so much, Priya. Thank you for coming.
Thank you.
And then now we have a contact person.
Yeah, I mean, absolutely. I'm happy to help with any of these patients or any of your onc patients. I can either, I mean, feel free to email me. You can give me my cell phone. I'm happy to see any of these patients.
Thank you.
Take care.